Hey guys, welcome back. Next topic that we're studying is COPD Gold 2024 update. Gold would be standing for Global Initiative for Chronic Obstructive Lung Diseases. And the first thing that I would like to introduce as an update, though it was introduced in 2023 and has been written in the 2024 report, is PRISM phenotype. To make it simpler, I can say in Hindi, जैसे डायबिटीज से पहले प्री डायबिटीज होती है, impaired glucose tolerance होता है और उनमें से कुछ पेशेंट्स को फ्यूचर में डायबिटीज हो जाती है. वैसे this is gonna be a phenotype which in future can deteriorate into COPD, though some of them can revert back to normal as well. As you're aware, some patients who are having impaired glucose tolerance can go back to normal. Similarly here, some patients of PRISM can go back to normal as well. So let's look at the technicals now. You see, one of the important spirometric parameter for diagnosis of COPD is a FEV1 FVC ratio. This ratio should be less than 0.7 to call it obstructive airway disorder. But in the PRISM phenotype, you will notice in the definition it will be written that FEV1 FVC ratio is turning out to be more than 70%. And when I say that, it is literally like that you are tossing the diagnosis of obstructive airway disorder out of the window. मतलब you आप ट्रैश कर रहे हो diagnosis of obstructive airway disorder को, क्योंकि ये रेशो satisfy नहीं हो रही है. But at the same time, you will notice that when you check out the FEV1 of these patients, normal is always more than 80%. In these patients, when you check out the FEV1, even after giving a bronchodilator, BD means bronchodilator, it will always turn out to be less than 80%. This basically means this is the starting of the disease, because FEV1 is turning out to be less even after a bronchodilator, though the ratio at the moment, which is the important diagnostic criteria for, diagnosis of obstructive airway disorder at the moment, is not being satisfied. So this is the starting of the disorder. Well, PRISM phenotype will be seen in most of the time tall, thin smokers. So in the literature, you will see it will be written former smoker, and he will also say low body mass index. That is why, when I've been describing emphysema, I've always said a tall, thin smoker. Now, as far as the story goes for PRISM, about 40 to 50% of cases who are suffering from PRISM at the moment, in the next 5 years, they can deteriorate into COPD. But it is not a guarantee that all of them will deteriorate into COPD. Some can also exhibit a transition to normal. So what we have tried to do with respect to demonstration of the PRISM phenotype is that we are trying to pick up the disease relatively early, so that we can go in with preventive strategies and we can prevent the disability that would be developing in the case. After all, the objective of medical science at the moment is early diagnosis. Like, we don't wait for diabetes mellitus to occur. We do annual medical checkups and we identify impaired glucose tolerance. Similarly, in fatty liver, you see we have stages like non-alcoholic fatty liver disease and then non-alcoholic steatotic hepatitis. That NASH, before it occurs, we can identify NFLD. You see, I would suggest you to also, after this video, read up fatty liver, which is very common in India nowadays. There was a study by by AIMS Hospital saying that 33% of Indians could be suffering from fatty liver. That's non-alcoholic fatty liver disease. And fatty liver can reverse back to normal. Just like I've said, impaired glucose tolerance can revert back to normal, fatty liver can revert back to normal. Similarly, I'm saying that the PRISM phenotype also has been shown to revert back to normal, though in a large number of cases. However, the deterioration will occur into COPD in future. Now, once we get this first update, the PRISM phenotype, next our objective would be to study the etiologies of COPD, where it's written terms like COPD-G or COPD-D. So let's look at them one by one. COPD-G would mean that there is a genetic reason behind it, there is a genetic cause behind it. And one of the very important genetic cause to be remembered is alpha-1 antitrypsin deficiency, which is going to cause a pan-acinar emphysema with development of liver cirrhosis. I would also like at this outset to remind you that alpha-1 antitrypsin deficiency does not mean that alpha-1 antitrypsin is not being produced. It is being produced by the liver, but it is not getting excreted out of the liver. So production is okay, production is normal, but the excretion out of the liver is defective. So it keeps on accumulating in the hepatocytes, and therefore we get damage to the hepatocytes, and therefore we get development of liver cirrhosis as well. So the reason why we get cirrhosis in alpha-1 antitrypsin deficiency is impaired excretion of alpha-1 antitrypsin, and the accumulation of it inside the hepatocytes causes damage, and therefore liver cirrhosis ensues in these patients in future. That's why in pathology, the pathologist will always say PAS positive inclusions inside hepatocytes. Normally we read about PAS positive inclusions with respect to malabsorption syndrome in Whipple's disease, Tropherma whippleyi, if you remember. And then we also read about PAS positive inclusions in alpha-1 antitrypsin deficiency as well. Then when it comes to COPD alphabet with the, the ending is capital D, it means that it could be a developmental defect. there is a possibility that this patient, when he was a child, he might have required a ventilator support as well. One of the commonest forms is anyway gonna be cigarette smoking, or like in India, in rural India, it might be BD smoking as well. But COPD-C basically means the etiology is cigarette smoking. And then a lot of us in India, especially Delhi, especially in northern India, people staying around Punjab, I mean, you know what happens in northern India every time. In the month of November and December, there's so much of smog, there is so much of pollution. So a lot of us might actually be suffering from COPD because of the environmental pollution. Plus, in rural India, they have this kitchen in the house in which they use wood for cooking. Though government of India is having all those schemes, no, that Ujjwala scheme available. So the point is that why government is asking us to give up that subsidy on LPG cylinder is so that these people can actually cook on a much more healthier way of fuel. And in rural India, women would be having COPD not only because they might be smoking a BD, but biomass burning also contributes to the same. And like cooking on a gas stove could contribute to development of COPD in a woman in future. Then for COPD-I, it means infections. Most of the time, these are again going to be childhood infections, which in later could manifest in the form of COPD. The next thing is very interesting, that is association with asthma. So COPD can coexist with asthma. That's a possibility. And in large number of cases, we may not be able to identify the etiotype as well. So we will say unknown cause. So that's another update, that they've just added these alphabets after COPD just to determine and let the doctor identify which is the etiotype of COPD. Because like let me say, if it is biomass burning or exposure to those fuels which are going to produce a lot of carbon that's going in the lungs of these patients, then the preventive strategies would play a very, very important role. Having talked about etiotypes, the next thing that I'll talk about is the classification, where we talk about mild, moderate, severe, and very severe. Now he does not use these terms like mild, moderate, severe, and very severe. He classifies them as gold 1, 2, 3, 4. So let's look at the first and the foremost thing, that for diagnosis of each of these categories, the FEV1 FVC ratio should always be less than 0.7%. That is the first and the foremost thing. And along with this, the second thing to be remembered is that in Gold 1, which is the mild variety, the FEV1 of this patient is more than 80%. I've seen a lot of doctors making silly mistakes in the exam, and they mess up between Gold 1 versus the look at the definition and the arrows here. They mess up with the definitions between Gold 1 and Prism. Prism will have arrows which were opposite. If I just go back to my previous slide, just focus on FEV1 value. It's written to be more than 80% at the moment. When I was teaching you regarding Prism phenotype, I said FEV1 is less than 80% and the ratio was more than 0.7. So this entire update will be most of the time data. So I would like you to just get used to the data, and a lot of people get, they mess it up in the exam. Though here you might be saying, sir, it's so simple, what is the big deal? But in the exam, no, because you have to remember 19 subjects, so there can be overlap of information. And that is the reason why I find people get this wrong. So one, you have to get the data correct for Gold 1 versus the Prism phenotype. The arrows are going the other way around. In the Prism phenotype, I'll just make you revise once again. FEV1 is less than 80%, but this ratio is more than 0.7. Then things will become relatively easier for you. So I don't think so that he'll ask you Gold 2, that is moderate COPD, in which the FEV1 will be between 50 to 79%. If he will ask you in the exam, then, and he has done that in the previous NEET PGs, that is between severe and very severe. Because again here, most of the time we tend to remember severe only. Who remembers very severe? And he knows that we can fall in the trap. So for severe, the FEV1 of the person will be between 30 to 49%. And for very severe variety, it will be FEV1 less than 30. When it was asked in the exam, he had asked severe variety. A lot of guys casually answered it as less than 30%, which is not the case. As I explained to you, for the severe variety, the FEV1 values will be between 30 to 49%. And it is for the very severe variety that the value would be less than 30%. So this table is an important one, and there could be errors, or I could call them silly mistakes with respect to the arrows direction that can be put up. You see, definition of Gold 4 is, I'll state that again. What is Gold 4? Very severe COPD, that implies FEV1 less than 30% plus demonstration of FEV1 FVC ratio less than 0.7. What is Gold 3? Your answer would be, it is FEV1 between 30 to 49 plus FEV1, FVC ratio less than 0.7. The plus word has to come in, all four of them, and along with this downgrade of FEV1 values are suggested to be remembered by you. Next comes the aspects of what are the interventions that would be improving survival in these patients, what are the mortality reducing interventions that would be done. So first and the foremost would be to quit smoking or like smoking cessation. And when you tell this to the patient, most of the time he's gonna laugh on you and say, come on sir, I mean, how can I quit smoking? Well, you'll just keep a straight face and say to him that cigarette smoking is a disorder of sensory motor manipulation. You see, when you observe smokers, they get a lot of kick out of manipulating the cigarette between their fingers. They get a lot of kick out of manipulating the cigarette between their lips and then blowing those rings of smoke. And you tell him you're doing it because you don't have anything else to do. You see, do not begin your consultation by saying that you're gonna die of a cancer, because he sees the picture of cancer on the carton of a cigarette every day. And if you're gonna tell him that, well, you're gonna die of cancer, he'll say, sir, I know about it, talk something else. So never begin a consult on a negative note. You have to begin on an opening positive note. And that is why you will tell him that, it's more of a habit disorder, that you are doing it because you don't have anything else to do in your life. That will hurt his ego a bit, not to the level that he'll get up and leave a consultation, but at least he will be all ears and listening to you, that okay, what is the doctor saying, that I'm having a habit disorder, impulse control disorder, I just control, I just need to get that fix of cigarette smoke. And then you will gradually introduce to him that, well, there are better ways of spending their life rather than blowing on a stick of cigarette. And we can suggest you methods by which you can quit smoking, which would be most of the time in the form of nicotine replacement therapy. And you will tell him that lots of time you don't need to even come to me for that. You can just go to any chemist shop and purchase nicotine gum. There are transdermal patches also, lozenges also available. So nicotine gum, nicotine patches can be used. Counseling obviously plays the most important role. Willpower of the patient will obviously play a most important role, but along with that, nicotine replacement therapy will matter. Another drug that has been used with a fair amount of success is varenicline. This would be a drug that would be acting on a special receptor in the brain, which gives so-called pleasure and causes a dopamine release in the brain. So this is a alpha 4 beta 2 nicotinic receptor. And from the pharmacological perspective, I would like you to remember that this drug is not an antagonist, it's a partial agonist. All of you have sufficient knowledge in pharma to know that even partial agonist would be blocking the action. So the so-called pleasure, the so-called relaxation that a guy gets out of cigarette smoking would be curtailed once varenicline would be used. Apart from this, other drugs which are available are like nortriptyline, bupropion. So I'm not writing about nortriptyline and bupropion here. You can read them from pharmacological domain as well. But if they ask you that what is the best way to quit smoking, the answer would be nicotine replacement. And quit smoking or smoking cessation is one of the first interventions that will improve survival and thereby decrease mortality in these patients. The next thing would be supplemental oxygen. When I talk about supplemental oxygen, I'm talking about low flow oxygen that is to be given to this patient with the help of nasal cannula. These nasal cannula will be very transparent and they can, be kept on the nostrils. And the oxygen flow rate would be usually at a rate of about 1 to 2 liter per minute. And our objective would be to improve the amount of dissolved oxygen in the blood of these patients so that they can go about their daily activities. I mean, a lot of these patients might be so breathless that even going to washroom might be a big deal, or changing clothes might be a big deal. So I want to improve the work capacity of this patient by giving low flow oxygen. Then the next thing that is being mentioned here is more valid for emphysema patients because there is bulla development, and bullas would be causing wasting because there is blebs and then bulla formation. So it's wasting of air in the lungs. So what we can also do in these patients is bullectomy. Bullectomy would be written in simple English as lung volume reduction surgery. So these are three interventions that will improve survival, decrease mortality, and then we also need to introduce drugs. Now, what are the drugs that would be introduced? We'll be introducing long-acting beta-2 agonist, we'll be introducing LAMA, and we'll be also introducing inhaled corticosteroids. And in the MCQ, if they ask you to select one, though I mean all of them are playing a role, but the single best answer from the drug perspective, all these four interventions are gonna play a role. This is the single best answer from the pharma perspective. I'll repeat that once again. The most important intervention is obviously to prevent further onslaught of damage. That's the first thing. Then is supplemental oxygen. This part number 4 that I've written is exclusively from pharmacological perspective, that they ask you that, okay, which is the main drug that will reduce mortality? Then your answer will be given as LAMA. Will be giving tiotropium to these patients. As far as the role of inhaled corticosteroids is concerned, most of the time you will see in the textbook a star written, because inhaled corticosteroids will usually be guided on the basis of eosinophil count. And you will notice that in COPD patients, if eosinophil count is more than 300 per cubic millimeter, that is benefit of inhaled corticosteroids would be done. Point number 4 in MCQs is also written as triple inhaled therapy. That is again a MCQ statement, because traditionally we read about triple therapy for H. pylori, where you are having two antibiotics like clarithromycin, amoxicillin with lansoprazole, pantoprazole. So that would be triple therapy for H. pylori. Then we have triple therapy for rheumatoid arthritis also, where we talk about drugs like hydroxychloroquine and sulfasalazine and methotrexate. So triple therapy is read in rheumatoid arthritis also, but then we are talking about triple inhaled therapy that would be valid for patients of COPD. So these are 4 interventions that improve survival, that are gonna reduce mortality in COPD patients, with special emphasis on LAMA, which is the single best answer from the pharmacological perspective, and inhaled corticosteroids to be used in those cases where the eosinophil count is going to be usually exceeding more than 300. Next, we'll study regarding MMRC grading of dyspnea, that is Modified Medical Research Council grading of dyspnea. Like in congestive heart failure, we have NYHA, New York Heart Association. Here we are talking about Modified Medical Research Council grading of dyspnea. So let's look at the data. You see, I will say that person is having grade 1 dyspnea. That is when this person will be having dyspnea on going up a small incline, like he is going upstairs or is walking up an incline, or for that matter of fact, if he is walking on a flat surface, then on walking fast there would be breathlessness experienced by this chap. But when it comes to grade 2 dyspnea MMRC, this means that this person is like going for a walk in the park and he's walking slowly. You see, the difference between grade 1 and grade 2 is that in grade 1, when he walks fast, that is when the breathlessness is perceived by the patient. But here I am saying that his wife is walking with him, or another man who's 65 years of age is walking with him. So for an age matched individual, he will walk slowly than the peers. What I mean by peers is that his wife is also 65. He says, I walk slower than her. Earlier, I mean, I could, catch up with her. I could walk faster. But this cigarette smoker now walks slower as compared to peers. And you asked him specifically, okay, what happens if you try to walk as fast as your wife? Then he says, I tend to get breathless. In contrast, when we look at grade 3, this is what will happen. This particular chap, he will walk for like 100 meters or 100 yards and then he will stop. So I said, okay, sir, you catch your breath and then walk again. So he will again walk 100 yards, and then it may not be 100 yards, it can be 80 yards also. But the point is, he will walk a short distance, then he's going to stop and he's going to just put up his hand and say, no, I need to catch my breath. If you ask him to resume walking and say, can you try walking a little extra than what you walked as compared to what you walked, I would say a couple of seconds before, he will say, okay, I will try. But again, the same thing will happen, that this guy will stop once again. So what you're noticing at this particular point is that the person will walk, but he will stop intermittently. And most of the time, the ability of this individual to walk a certain distance will depend on the total lung function or the lung status of this guy. I mean, some people might be able to do 120 yards, some might be able to do 80 yards. I mean, that depends on case to case basis. But if I say MMRC grade 4, that means that the person is extensively breathless to the level that even too breathless on, let me say, changing pair of clothes, or he's even too breathless on going to bathroom. And I told him, like, for a good health, I had told this guy that, you see, there is a park in front of your house. Like, he lives in a big house and there's a park in front. And I told him, you should go and take a short walk. He says, no, sir, I'm just incapable of it. I mean, this guy is sitting on a chair. He's watching his grandchildren play in the park. There are beautiful flowers. The birds are chirping. I said, why don't you go out, and just take a short walk? He says, no, sir, I don't feel confident. I feel as if I don't have sufficient amount of air in my lungs. I tend to get breathless. So when I say too breathless, I'm going to bathroom, or too breathless to leave house. And it was like a well manicured lawn in front of his house. Not that he has to walk, he has to cross a busy road and then go to some park. Not like he has to walk extensive distance. I said he lives in a big house with a courtyard in front where like it's a good manicured lawn. And he says, no, that I am too breathless to leave the house. So that would be grade 4. And it's important for this to know, because we are going to be talking subsequently with respect to how do we categorize our patients of COPD into category A, B, and E. That's the 2024 update versus categories A, B, C, D, which is given in the 21st edition of Harrison. But for that, I first need to introduce the MMRC grades of dyspnea before you. Next up is CAT, that is COPD assessment test. This is a questionnaire which is filled by the patient himself. Though the point is, a lot of time Indian patients may not be very good in English, so you will have to assess them. The minimum score based on the symptoms of the patient for this test would be a score of 0. The maximum score per question would be a total of 5, and then total of 8 questions present here. So let me say if he mentions 5, which means the worst for each one of those symptoms, like if he is having cough all the time, that would be 5 points, or he's saying that my chest feels tight all the time, that's again a score of 5 points. So the maximum score possible would be 8 into 5, that is 40. On the other hand, the minimum score possible in this would be 0, and I can say higher is the score in COPD assessment test, it means more symptoms are present in the case. Now what I say on the next slide is the most critical part of this entire video that we are discussing, and I would suggest you to do this activity yourself with me, which is that we're gonna talk about on the x-axis you can write the word symptoms, on the y-axis you can write down the risk. And for risk, I can say what I mean by risk in COPD is the risk with respect to exacerbations, because these patients can deteriorate, especially if they're having COVID-19 or they're suffering from RSV infection, then COPD can have a worsening, and you might have to put the patient on non-invasive ventilation. So let me say a person is having 2 exacerbations in 2023, or I can say there was one of them that was so bad that it required hospitalization. I said 2 things. If a person who's having COPD is having at least 2 exacerbations in last 1 year, or he had 1 exacerbation that was so bad that it required a hospitalization, then I will say that my patient is having a high risk. So let us just on this particular x and y axis write the word high risk 2 times. In contrast, I hope that you're doing this activity with me. Another possibility is that our case had only 0 to 1 exacerbation, and there was no need for any hospitalization. So if there is no need for hospitalization and he had only 0 to 1 exacerbation, then I will write that my case is a low risk case, and I would like you to write this low risk at least 2 times. Once you've done this activity, we move to the next step, which is that we're going to talk about symptoms. You see, symptoms would be one that would be assessed by the doctor on the basis of MMRC grading of dyspnea. So if the MMRC grading of dyspnea is between 0 to 1 versus, let me say, a patient who's having MMRC grading of 2 or more than 2, in a sense that he's slower in walking as compared to other people of the same age. I'm not saying, you see, a kid, I mean, let's take a grandchild of this old man. A grandchild will run very fast. So I'm not asking him to compare with his grandchild. I am asking him to compare with another person of the same age. It could be a relative, it could be a neighbor, it could be his wife. And I'm noticing this guy walks relatively slower, or he might have to slop intermittently as well. Similarly, on the left hand side, I'm writing that the COPD assessment score of the patient is turning out to be less than 10, or CAT values turning out to be more than 10. Then I can say for this category of patients who are having MMRC grading of dyspnea between 0 to 1 and CAT score also less than 10, I'm writing the word that these patients are having low symptom profile. Low symptoms, low risk. On the other hand, you can also notice that the case on the right hand side, if there is a MMRC value that is at least more than 2 and the CAT value is more than 10, that means that person is suffering more. So I'm writing the word high symptoms in this particular case. So I'm trying to create these categories. You need to do this with me so that you can get a better understanding, because if you're having this printed in your notes, it would not make any sense to you. You need to do this by your own activity to understand that a low risk, low symptom patient, which is classified as a class A patient or category A patient, he will be having the least requirement of drugs. You see, we need to use our firepower proportional to the amount of drugs that the person is using. Let's look at category B. Category B would be the one of group B, as I can say. The group B would be who's low risk with high symptoms. But let me move on the extreme right hand side to category number D. And this category number D would be because MMRC is more than 2 and CAT is more than 10. So I'm writing the word again high symptoms in this particular case. So this is gonna be the one case or one particular case where you will have to use the max amount of drugs. I mean LABA also, and possible use of inhaled corticosteroids as well. And for the left hand side, I'm writing the word low symptoms. Why am I writing low symptoms? Because MMRC of my case was 0 to 1, CAT was less than 10. So what you need to do is either on the x-axis and use 2 different color pens. Either on the x-axis, divide the x-axis into 2 and write low symptoms versus high symptoms, low symptoms versus high symptoms 2 times, and then put up the data for risk. I would personally suggest you to first note down the risk part, because that is important, because patient who's having exacerbation will require a hospitalization. So if a person has been admitted to a hospital or there are 2 exacerbations, I'll call him high risk, otherwise low risk. And you can create these categories by yourself. Like I have put up 4 categories. And why I asked you to do this activity with by yourself in your own handwriting is so that you can develop a visual memory of the same. This table is what is given in the 21st edition of Harrison, and what I'm going to say next will be a little of a dampener in a sort, that in the 2024 update of COPD, the gold classification definitions per se, they have merged C and D into category E. Now there is no category C and D in the update, it is a category E. I know when I say this, the query of yours is, then what was the need of doing all this activity? Why it is to be done is because if they are going to ask you the question in the exam, you have to answer from Harrison, and this is Harrison has mentioned it. That would be, these four group C is created here based on the symptom profile and the risk profile of a case. However, if he himself will say the word update, then you will be answering as A, B, and E assessment. Otherwise, the standard would be A, B, C, D assessment in COPD. When I say this, the query of most doctors is, come on, sir, what is the need of learning both the facts? Well, they did this in NEET PG for diabetic ketoacidosis, that they introduced an update which was introduced only 2 months before the NEET PG exam. If you've been to the diabetes section, I think you're relating to what I'm saying. If not, I'll just say it verbally before you. You can refer to the DK video per se, which is that the insulin bolus shots that were initially given before insulin drip have been discontinued, and we give insulin drip to the patient right away after giving IV fluids to this patient of diabetic ketoacidosis. So that's an update from DK perspective for children. Similarly, an update to be remembered here will be, if he will himself say GOLD 2024 update, then the categories which are being created would be A, B, and E. Otherwise, it is A, B, C, D, and we'll be discussing the pharmacological treatment of these also. But first and foremost would be to understand what you mean by the word. When I say category A, that would be a low risk, low symptom profile, and it's always advisable to practice this on an X and a Y axis so that you can remember this data on a long-term basis. Coming to the pharmacotherapy of these various groups, as far as the first one is concerned, that would be group A. He says we can be using any bronchodilator. Even a short-acting bronchodilator can be used on a SOS basis whenever the person is having symptoms. However, once he goes into group B, let's just practice, was where the symptoms of the person have increased. He's still a low risk patient. He has not been admitted in the hospital in the previous 1 year, but still is having a high symptom profile. So I would like to turn a little more aggressive. And therefore he says that you can be either introducing LABA or you can be introducing LAMA. LAMA would be like tiotropium, that would be introduced in this case. But if he upgrades to group C, then you will be giving LAMA on a long-term basis, regular basis, and the dosages would relatively be higher as well. When it comes to group D, he says that either you have to upgrade the dosages of LAMA to max, or he says it is advisable that now you start giving the two together, LAMA plus LABA. You see, earlier in category B or group B, you were noticing that it is LABA or LAMA. Now it is plus. So addition has to be remembered. I mean, lots of time in the exam, confusion can be between B versus D, because in B it is a OR and in D it is a combination. Also keep on listening to this fact that lots of time he will also mention not LAMA and LABA together, because it will be easier for you, because you know that LAMA is one of the major mortality reducing drugs. So every intervention we are doing is to reduce the mortality, but on a comparison basis, I spoke about LAMA. That is what Harrison says. But then he says we can also be using LABA when inhaled corticosteroids. Inhaled corticosteroids, whenever is written, he will always write this word EOS. That means eosinophil count of the patient is turning out to be a value more than 300 cells per microliter. Now, as far as the update is concerned, that is 2024, they have merged C and D. These C and D have been merged. Groups C and D are merged into group number E, and now you will see that the treatment will make much more sense. He says for group A, he says you can be using any bronchodilator. It could be short term, it could be long term on a SOS basis. But the moment he goes into his symptoms have become much more aggressive. That is when you need to go in for combination of LAMA plus LABA. So here you can see that we are little being more aggressive. Earlier it was OR, and now in 2024 update he's saying that you are going a little more aggressive. You are using a combination of the two. And if he goes into group E, then you are using the above two plus you are adding inhaled corticosteroids. So I'll put it like this, that in the 2024 update it is much more simpler. In group B you are using 2 drugs, in group C you are using 3 drugs. Obviously that addition of inhaled corticosteroids is based on this data of eosinophil count more than 300 for both of them. But then 2024 update is much more simpler and straightforward, 2 drugs and then 3 drugs to be used, in contrast to the one that is given in Harrison. I'll reiterate once again, unless and until he says the word update, do not answer this as what I've said on the right hand side. You have to answer it as far as the table in Harrison itself is concerned. But yep, if he mentions the word update, then the data on the right hand side also has to be remembered. I know it sounds a little, harsh on me to ask you to remember two pharmacological approaches to the same disease, but that's how harsh our system is. So I would like you to just bear on and remember both of these informations. The next aspect to be remembered would be, when should you be giving supplemental oxygen to patients of COPD? In case we find that on ABG the PO2 of the chap is less than 55 millimeter of mercury, or if we are using a pulse oximeter and the saturation is turning out to be less than 88%, that is when he should be put on low flow oxygen using a transparent nasal cannula at a rate of 1 to 2 liters per minute. And the number of hours he takes will be based on his comfort level, but more is the number of hours he will take this, the quality of life will improve. There is a second criteria as well, that is if the PO2 of the person is between 55 to 60 millimeter of mercury, but he says that at this point of time there is evidence of, like, this chap is having any of the two that I'm going to describe. Either this chap is having features of right ventricular failure, or this guy is having a elevated RBC count. You're aware that in COPD, because of the hypoxia component, there would be secondary polycythemia, and therefore the RBC count of these patients would be skyrocketing. If you take a blood sample of a COPD patient, you will notice it will be dark in color, and it will also be relatively, I would say, higher chances of getting clotted in the syringe. If you are not gonna add the necessary anticoagulant, the chances of it getting clotted in the syringe would be higher because the RBC counts are relatively higher. So there are two indications for giving oxygen. One is a standard one, SaO2 of less than 88. But if the PO2 of the patient is a little higher, but there is evidence of erythrocytosis, or there is evidence of right ventricular failure, then the threshold will be relatively lower for us. At the same time, what is the target saturation to be obtained? By giving low flow oxygen, we have to attain a target saturation of more than 90%. And we have to keep on titrating our drug treatment on the basis of whether there is an exacerbation or only there is dyspnea that is experienced by the patient. Because if there is going to be exacerbation, then I need to not only increase the amount of drugs, but at the same time, first I obviously need to check whether he's taking the drug properly or not. So the administration of inhalers has to be checked, the technique has to be checked, but after that I need to keep on increasing the dosages and then add inhaled corticosteroids as well. So here I'll try to explain when would you like to give supplemental oxygen to your cases. Next is ECOPD, which is also called as exacerbation of COPD, which will classify as mild, moderate and severe. You mainly need to remember the severe variety. You will say mild exacerbation when the respiratory rate is less than 24 per minute, heart rate is less than 95 per minute. Like this guy could have had an exacerbation due to COVID-19 or due to respiratory syncytial virus, which is why vaccination for these patients will also be discussed. The oxygen saturation is turning out to be less than 92%. CRP at the moment is less than 10 international units. And on a visual analog scale, like visual analog scale would be like person is breathless. So if he's gonna be like, anxious about hypoxia, then his lips would be curling downwards versus a person who's having pursed lip appearance. So I can say that on a visual analog scale, though not very important from the exam perspective, the facial expression of the patient would also tell you. A bewildered look due to hypoxia is very easily picked up. The visual analog scale dyspnea score is less than 5. For moderate, I would be describing multiple parameters before you, and at least 3 out of these 5 should be positive in the moderate exacerbation of COPD. That is, the respiratory rate is more than 24 per minute, heart rate is more than 95 per minute, oxygen saturation is still less than 92, but CRP in this case is turning out to be positive. Like I said, lots of time inflammatory states because of infection would be present, so the CRP will start turning positive, and the visual analog scale, the dyspnea score is turning out to be more than 5, and if 3 out of them 5 are satisfied, we'll say moderate. Now for the severe variety, it is same as moderate. For the severe variety, it is same as moderate, but an exception is there, and that exception is the one which you basically need to remember, which would be that when you check out the ABG report, the PCO2 will be more than 45 millimeter of mercury. Every time in a COPD patient there is an exacerbation and there is a development of respiratory acidosis, you will have to go in for NIV, that is non-invasive ventilation. This is an indication, actually severe COPD exacerbation where there is a respiratory acidosis and PCO2 is rising. There is a respiratory acidosis, carbon dioxide narcosis developing in a patient. That's an indication for NIV to be deployed. Apart from, obviously the drugs will be given, LABA, LAMA, ICS will be used, but the main approach for severe COPD is non-invasive ventilation, which has been asked a large number of times. The usual one-liner question will be that the most important indication for NIV usage is. Obviously, we were using NIP for management of even severe COVID also. But at the moment, when you focus on COPD, it's the severe COPD patients who would require non-invasive ventilation using a tight-fitting face mask. The second indication to be remembered for NIV is flash pulmonary edema or acute pulmonary edema due to congestive heart failure or cardiogenic shock. A quick look at contraindications for non-invasive ventilation as well. Though these have been discussed in the video of mechanical ventilation, this will be a repetition because it is given in mechanical ventilation section in emergency medicine as well. But on a broad perspective, I would like to say that if there is a hemodynamic instability, by hemodynamic instability, I mean like a person is having, let me say, vomiting of blood, or let me say he's having a CNS problem, there is a swallowing impairment occurring in a patient, he cannot protect his upper airway, there is a severe GI bleed. I said if the BP of a patient is crashing, or if the sensorium of the patient is getting affected, or if there is a craniofacial dysmorphism present where putting on a tight fitting mask will not be present, I mean there could be cosmetic reasons why non-invasive ventilation would not be required. So as such, I can say if a person is not in his senses, you see, if a person is not in his senses and he vomits and you put in a tight fitting face mask, the vomitus, would not be able to escape and it can actually go in the lungs and the person can deteriorate. So that is why these contraindications for non-invasive ventilation have been described. More details for and how to remember these contraindications for non-invasive ventilation have been discussed in mechanical ventilation part, but just giving you heads up from the perspective of hemodynamic instability and the GCS values in a patient. I mean a comatose patient, cosmetic issues, or hypotension due to bleeding or post myocardial infarction, these patients may not be able to handle a non-invasive ventilation. One of the most important indication for this would be, apart from hypoxia, would be PCO2 values going more than 45, which in some MCQs might be written as more than 6.5 kilopascal. I mean, in America, sometimes they may not be using millimeter of mercury, but still you'll be able to pick up that there is acidosis because pH is less than 7.35, and because he's talking about a COPD patient, so it has to be presence of respiratory acidosis, where once he goes into severe COPD, the saturation levels will begin to fall dramatically and aggressive intervention needs to be done. The most important step for management of this patient is obviously drugs, but if he says the most important intervention to save a life in severe exacerbation of COPD, answer is non-invasive ventilation. Obviously take care that none of the contraindications are present. Another update is that he has said that you have to test all the patients of COPD for alpha-1 antitrypsin deficiency because we now have availability of alpha-1 antitrypsin. I mean, we can produce it from blood of normal people. So alpha-1 antitrypsin augmentation is possible. We can give alpha-1 antitrypsin to our case and we can reduce the development of pan-acinar emphysema. For alpha-1 antitrypsin deficiency, a bit of genetics also will practice here. Like he will ask you which chromosome is defective, which gene is defective. So I give you a few seconds to think about the chromosome that is involved without looking at the notes. Yes, guys, I know that you read about alpha-1 antitrypsin pathology also. I mean, you have printed notes, so you obviously know the chromosome number. But otherwise, I think that genes and chromosomes are like, data that has to be noted down in your own handwriting. Only then it is possible to remember. So for alpha-1 antitrypsin deficiency, it's chromosome 14 that is defective. We discussed about chromosome 14 being involved even in hypertrophic cardiomyopathy, just to remind you from the cardiology perspective. Now we have a SERPINA1 locus on this chromosome, and there are a couple of alleles which are described for alpha-1 antitrypsin also, which are called as M allele, then is S allele, and then would be a Z allele. M allele would mean that the levels of alpha-1 antitrypsin are perfectly normal. I mean, the hepatobiliary excretion of the same is perfectly normal. S would mean that the values are relatively lesser, and that is why the pollution exposure or biomass fuel burning can contribute to emphysema in these patients, because alpha-1 antitrypsin normally helps in neutralization of elastase. But now if it is less, alpha-1 antitrypsin being released less in the blood implies that the ability to handle elastase will not be present, and the Z allele basically implies that there is a very severe deficiency present. So lots of time in genetics you will read about this PI and this superscript Z would be present. This subscript basically would tell you, that's an MCQ statement in itself, that what is the most common form of alpha-1 antitrypsin deficiency. Then it is PIZ phenotype that is to be remembered as the most severe form of deficiency, and the augmentation of this is possible using blood products. Obviously, testing of the patient for hepatitis B should always be done, and he also says that hepatitis B vaccination must be done in these patients before alpha-1 antitrypsin augmentation is done using blood products. I repeat that again, because we are using blood products, chances of transmission of hepatitis B in the patient is possible. So vaccination with hepatitis B must be done in these patients before alpha 1 antitrypsin augmentation therapies tried for patients of alpha 1 antitrypsin deficiency, failing which they will develop pan-regional emphysema. Plus, since I talked about vaccines, so they have updated the list of vaccines also in the 2024 update. Obviously, influenza, COVID-19, pneumococcal pertussis, that's the acellular pertussis vaccine, shingles, chickenpox. But now they've added even respiratory syncytial virus vaccine. Obviously, for this, they mentioned patients more than 60 years of age. But the point is that they've updated the list for vaccinations as well. So in the exam, he will not ask you this 2024 update for part number 6. He will say which vaccine should be given. So it's logical. I mean, COVID-19, influenza is anyway to be given. Pneumococcal vaccine, leading cause of bacterial pneumonia. So the additional ones, which I think from the exam perspective to be remembered, is pertussis, shingles, and respiratory syncytial viruses. And then macrolides also will be used in patients of COPD. Why? Because intermittent courses of macrolides are being given. Because azithromycin will not only be having an antibacterial activity, that is not an issue, but they'll also be having an anti-inflammatory action as well. So you will notice that if a person of COPD is having frequent exacerbations, then repeated courses of azithromycin are also being given. Obviously, like we'll be using oral steroids intermittently also if the exacerbation is severe. But the point is that azithromycin, what the role of azithromycin courses for patients who are having repeated exacerbations would be mainly because of its anti-inflammatory action. There are two aspects which is important, because patients who are cigarette smokers can develop lung cancer as well. And most of the time in lung cancer patients, he will always write in the MCQ pack year. So one, you should know the formula for pack year, which would mean that whatever is the number of cigarettes that is smoked by this individual per day, like he's smoking 30 cigarettes or whatever XYZ number of cigarettes, divided by 20. Why 20? Because one packet standard would be having 20 cigarettes, and this would be multiplied by the number of years that he has been smoking. Like he has been smoking for 10 years, he has been smoking let me say 30 cigarettes for past 10 years. So his pack years will be 30 divided by 220, that is 1.5 into 10, that would be 15 pack years. That is how the description would be given. 15 pack years description would be given. Lastly, to finish this topic, I'll also mention regarding board index. Board index is to predict mortality in COPD, where we'll take into consideration B, that would be body mass index, so that is easy. Then for airway obstruction, what we'll take into consideration is the value of FEV1. I did mention those FEV1 cutoffs for gold 1, 2, 3, and 4, which I hope you will remember. The old terms were mild, moderate, severe, very severe. Now it's gold 1, 2, 3, 4. Then for dyspnea, we will take into consideration MMRC grading of dyspnea. I had already sensitized you to that for cardiology. We use New York Heart Association grading of dyspnea. Here we use the MMRC grading. And for exercise capacity, we will go in for a 6-minute walk test. We were using 6-minute walk test for exercise capacity, even in interstitial lung disease, and even in COVID time, when patients were at home, to decide whether somebody will require a hospitalization or not, we were using a 6-minute walk test, because after 6-minute walk test, saturation is falling. That means that person needs a hospitalization. So for board index, you need to remember BMI, airway obstruction for O, D is for dyspnea, and E would be for the exercise capacity using a 6-minute walk test. So these are the details that I would like you to remember for this topic, especially from the therapeutics perspective. Then I also want you to remember the aspects related to PRISM and also the ETO types of COPD that I've explained to you. So keep on learning new facts every day. As I say, always keep hammering, and knowledge is power. So you just need to keep on building your knowledge base, and you'll get on to the other side.